Welcome to the bonus content for the athletic groin pain episode. In this video, we're going to go over the clinical entities specific to groin pain. We will not be going over the evaluation for hip-related groin pain or the other causes of groin pain, as the hip-related evaluation is also in the FAI bonus content, so I'd encourage you to go check that out. And also, it'd be very extensive, and there's a lot of different evaluation processes that can go into it. So for this video in specific, we're just going to talk about clinical entities of groin pain itself, and then we're going to show some rehab examples that you can implement into the clinic to rehabilitate athletic groin pain. So for the beginning, we're going to go into the evaluation process, and we're going to start with adductor-related groin pain. So in the episode, as we talked about, adductor-related groin pain is the most common type of groin pain that you will find. To identify adductor-related groin pain, it is adductor tenderness and pain with adductor resistance. So if you can kind of externally rotate your leg for me. And so basically it's any tenderness along the adductor. It's more common going to be more proximal. So if you're palpating and you feel tenderness through there, that can be an indication. And then for the resistance part, we're going to have you go ahead and lay supine, head this way, feet that way. And then to identify the pain with resistance, you can have them just bring their knees together and then add resistance this way. If they have pain, that is another indication that it may be adductor-related groin pain. If you're in a tight pinch and you can't have them lay down, a lot of times how I'll have them go is go ahead and sit, and we'll have you face that way, legs hanging off. You can have them kind of do the same thing while seated. Go ahead and bring knees together. So if you're in a pinch and they can't lay down, you can also do it that way as well. So the next one is iliopsoas-related groin pain. In this case, we're identifying that the iliopsoas is the pain generator. This is identified with pain with resisted hip flexion and or pain with hip flexor stretching. To provide resistance against the iliopsoas, you're going to go ahead and bring your right knee up for me. And then you have them resist you as you push down. You can get pain from there to identify iliopsoas-related groin pain, or you can have them go into a stretch. So to stretch the iliopsoas to identify if it is the painful structure, go ahead and slide towards the edge of the table a little bit more. Butt's going to be kind of closer to the edge. Good. And then you're going to go ahead and lay back. You're going to bring this leg up. And then you'll apply a stretch there. If there's pain there, that could be another indication that the iliopsoas is the cause of the groin pain. The third entity that could identify groin pain is the inguinal-related groin pain. Essentially, that's going to be any tenderness that's along where the inguinal ligament will run. So if you find that ASIS, any pain along here, so any tenderness as you palpate can indicate inguinal-related groin pain. You can also get pain with abdominal resistance. So if you go ahead and lay supine, we'll go head this way, feet that way for me. Have knees bent, good, and then kind of go into a partial crunch. It doesn't matter, you can have here, or if you want, go ahead and sit up. And then applying resistance there, they can have pain. You can also, if you wanted to add the obliques to resist, different, the right or left shoulder to factor in the obliques as well, you can also do that. As we mentioned in the episode, they can have pain with Valsalva as well. It is important for inguinal-related groin pain that hernia is not palpated. If you do palpate a hernia, that is a different condition as opposed to inguinal-related groin pain. And then the last clinical entity for groin pain is pubic-related groin pain. As we all know, palpating the pubic bone is a little awkward, and each clinician does a little bit differently, so we won't actually be palpating. Essentially, it is any tenderness that's on the pubic symphysis or the adjacent bone. So if you have your athlete or patient identify where their pubic symphysis is, if that spot's tender, or even just going lateral to that, if that's still the tendered area, then you're looking at a pubic-related groin pain. So now that we talked about the evaluation process, as we said in the episode, now we got to do something about it. So now we actually have to do the rehab portion. So here are a couple of ideas to start your rehab. To start off, we're going to start with what most people know as their go-to adductor exercise, and that is the ball squeeze. It's very interesting identifying the ball squeeze or just having your knees squeezed together. It actually presented with a very high MVIC for the adductor longus and EMG signal for the adductor longus. So it is a very good exercise to isolate your adductors, especially if you're looking at the adductor longus. So to do the ball squeeze, go ahead and lay supine, head this way, feet that way for me. So for the ball squeeze, or just knee squeeze in general, you'll have them have an object. A lot of times it is a soccer ball or a ball in between their knees. And all they're going to do is apply gentle contraction to it. So basically it's kind of like a small concentric, maybe isometric contraction. Go ahead and relax, hold that long. And then that's essentially the ball squeeze. They're just essentially squeezing the ball with their knees, activating those adductor musculature. What I thought was very interesting, looking at the literature, this version of the ball squeeze, go ahead one more time. Go ahead and activate, good. Actually produced more force and had a higher EMG output compared to, go ahead and straighten your legs. The straight leg ball squeeze, where the ball is actually at the ankles. And then go ahead and same thing, go ahead and squeeze. Good, go ahead and relax. The reason I think this is happening is because this is a little more difficult, so being able to forcefully contract your adductors may be a little more difficult for patients. So that's why they're able to probably get a little more contraction out of the bent knee as opposed to the straight leg. But both exercises are very good to use. The ball at the ankles can also add a nice little element for knee stability, since it is now creating forces across the knee joint. So that's another consideration. Even though there's a lot of activity coming from the adductors with the bent knee, this might be a better progression because now you're starting to factor in other joints and how they're being controlled as well. So the next exercise that we like to show is just hip adduction. Most of us already kind of do hip adduction on the table. So go ahead and swing around. We'll go feet this way, head that way on your side, facing me. And we'll go ahead and bring this leg in front this way. This leg, toe to your nose, knee locked down. Go ahead and bring that leg up for me. Good, and go ahead and relax. All right, most of us do it that way. Go on one more time. All right, do an ankle weight on the table. Go and relax. This is great for someone who's not ready for more complex movements, who aren't ready to be standing. But for a lot of athletes, this is probably going to be really simple for them. We also want to try and get a little bit more of a challenge. So what I like to do is I like to add in standing hip adduction. It adds the element of being single leg, so they have to do balancing, core stabilization while they perform a movement in a more functional stance. So go ahead and stand up for me. So for this exercise, I'm going to use a band. I'm going to be providing the resistance, but you can also use this with a machine. You can have this band wrapped around a post so then just the athlete can perform it. But essentially what you're going to have them do, they're going to step in, and you're going to have it right around their knee. Go ahead and face forward for me. Then you'll bring your hip into adduction. Like that, and then out. Ideally, if they can do it without having to step down, that would be great. But if they need to reset each time, I'd rather them do that than trying to struggle with their balance.
Or foam rollers.
Or foam rollers as well. Some kind of stability surface as well. That can work as well if this is too difficult. Go ahead and relax for me. So if it becomes too easy from this perspective, from the knee, you can also go a little bit lower and then have the band around the ankle. It just adds a little bit longer of a lever arm. And then same thing, now you're having to account for forces across the knee. So that will add another element as well. The next one actually will use a band in a similar fashion. So what we'll have you do is go ahead and slide closer to me. And then go ahead and step through one more time. Now, kind of similar to what we were just doing with that single plane motion of hip adduction, what we can do as well is now add in a shuffle to it. So, or like a lateral walk, but this time, instead of the resistance being with a band on the outside to train the glutes, we're going to use the lateral walk to train the adductors. So go ahead and face forward. And what you're going to do is you are going to step going that way. And then you're going to go back. So the nice thing about this exercise is you get both elements of concentric contraction, so you're getting the concentric resistance here, but then also an eccentric contraction because she has to control her hip as she's stepping because the band is then pulling her back. So I like the lateral walk exercise because now we're starting to get the athlete moving. It's a very functional type of exercise. Another way we can start training the athlete a little more functional and to get more muscle groups involved, especially in creating stability across multiple joints in a triplanar fashion, is now utilizing the squat. The way you can emphasize a little more adductor contraction with your squat is starting to go with a wider base and even getting a little external rotation with your feet. So go ahead and widen your base for me, and then go ahead and go down into a squat. So you'll be able to get a bit more adductor activity by going into this alternate stance. It's not going to be a ton, but considering that the squat doesn't get a ton of adductor activation, doing it this way will then get a little more focus there, as well as you're getting more muscle coordination between the glutes, the quads, hamstring. Everything is now working together in that fashion, so it's going to be a little more functional of an exercise. And then, of course, you're going to get a lot more activation depending on the resistance. So you can add a goblet squat to it. You can do weights by your hands. You can go single arm with most of the weight. So you can get really creative depending on what you're trying to do to get more core stabilization, to add more resistance. It gives you a lot more to play with and get creative with your rehabilitation. So hopefully this video gives you some ideas when you get another groin pain patient. Hopefully it gives you an idea to streamline or organize your evaluation a little bit better. And hopefully you've gotten some ideas that can help you as you start planning your rehabilitation to get someone back from athletic groin pain.